You step into the emergency department, right? And it's 2 a.m.
Oh, always 2 a.m.
Always. And you are presented with a 7-month-old infant. The thermometer reads over 40 degrees Celsius. The child is sleeping heavily, and, the parents are standing right there, absolutely terrified, and they're looking to you for an immediate answer.
Yeah, that's a tough spot.
It really is. Suddenly, that comforting precision of medicine, like a clear broken bone on an X-ray, it's just gone. You are looking at a clinical landscape that is incredibly murky. So what do? Do you rush to order a lumbar puncture and start broad-spectrum antibiotics just in case? Or do you wait?
I mean, it is the absolute definition of diagnostic muddy waters. You have seconds to make a decision that carries massive consequences either way.
Exactly. So, welcome to this episode of Pathways in Pediatrics. This is the official podcast of the European Academy of Pediatric Societies, or EAPS. Today, we are exploring how to navigate those exact stakes.
Right, because it's something every pediatrician faces.
Absolutely. So we are pulling insights from a phenomenal recent EAPS step-by-step webinar that took place in April on the topic of managing fever in the child. In that session, leading experts, Professor Christelle Gross-Le Guin, Professor Simon Nadel, guided participants through some really intense, real clinical scenarios.
Yeah, their goal was to help healthcare professionals distinguish those, low-risk situations from the 5 to 15% of cases that require urgent investigation and treatment.
Which is the tightrope we all walk.
Yeah.
Because the overarching theme they tackled is this huge tension between two incredibly dangerous extremes.
Right. On one side, you have the immediate catastrophic threat of missing an invasive bacterial infection.
Like meningitis or bacteremia.
Exactly. And Professor Nadel actually highlighted a recent meningitis outbreak in the UK just to emphasize that this isn't just theoretical. Even in high-income countries, severe sepsis carries a brutal 20% case fatality rate.
20%, that is just staggering.
It really is. And a 30% rate of long-term sequelae for the survivors.
Which totally explains the pressure we all feel, I mean, the Surviving Sepsis campaign really drilled the golden hour into us.
Oh, absolutely. That push to initiate antibiotics immediately.
Right. But then Professor Gross-Le Guin introduced the other side of the scale, which is antibiotic resistance. I mean, the World Health Organization classifies this as a top 3 global threat to human health.
Yeah, and she shared a case from her own intensive care unit that was just chilling. It was a baby in septic shock caused by Pseudomonas aeruginosa.
Let me guess, resistant.
Fully. It was resistant to all usual antibiotics.
Oh, wow. That is terrifying.
It illustrates the nightmare perfectly. Because when you're standing at the bedside and your entire arsenal of frontline drugs is rendered basically useless by resistance, the gravity of overprescribing becomes very, very real. We are running out of weapons.
I always look at it like using a flamethrower to get rid of weeds in a garden.
Oh, that's a good way to put it.
Right. Because, sure, you kill the immediate threat, but you scorch the soil so entirely that nothing healthy can grow back. And in this case, the soil is the child's microbiome.
That analogy is spot on for the biological mechanism at play here, because the webinar drew a very sharp line between early antibiotic exposure and dysbiosis.
Which is a lot more serious than we used to think.
Exactly. We aren't just talking about a short-term side effect like, an upset stomach anymore. When you use that flamethrower on a developing infant's gut, you wipe out the flora that is actively training their naive immune system.
So it actually alters their development?
Yeah, that disruption alters metabolic signaling pathways long-term.
Wait. So the antibiotics given in the first few months of life are fundamentally changing how the child's body processes inflammation and metabolism years later.
Exactly. The speakers presented data linking early antibiotic-induced dysbiosis to long-term insulin resistance, obesity, A to P, allergies, and autoimmunity. Yeah. If you give antibiotics purely out of fear, you might be trading a highly unlikely short-term risk for a guaranteed long-term biological cost to that specific child.
Okay, so if the consequences of guessing wrong are that severe in both directions, how do we stop guessing? I mean, obviously, for you listening, we know the classic red flags.
Right, the obvious stuff.
Right. If I walk into the room and see a purpuric rash, cyanosis, poor peripheral circulation, or, a child having a seizure, my heart drops. We are in the red zone.
Absolutely. No question.
But what about the less obvious presentations? Because I've always been taught to look at the intensity of the fever. Like, if that thermometer hits 40 degrees Celsius, my alarm bells are ringing. Are you really saying we should ignore a 40-degree fever?
I know it sounds crazy. It is a massive paradigm shift, but yes.
Really?
Yeah. Professor Gressligan presented robust data indicating that temperature intensity actually has poor discriminating power for sepsis.
That is so hard to wrap my head around.
I know, but if you isolate the temperature, even a blazing 40 degrees, the probability ratio for it being a serious bacterial infection just isn't convincing.
I am really struggling to let go of that. I mean, if a 40-degree fever isn't a reliable map of the pathogen's severity, what is actually happening biologically? Like, why would a basic virus cause such a massive spike?
Well, because the fever isn't a direct reflection of the bug itself. It's a reflection of the host's inflammatory response.
Oh, okay. That makes sense.
Right. When a pathogen enters the body, immune cells release pyrogenic cytokines. These travel to the hypothalamus in the brain, which basically acts as the body's thermostat.
Right, the thermostat.
And the hypothalamus responds by releasing prostaglandins, which reset the body's internal temperature target to a higher level.
So the body's doing it on purpose.
Exactly. And a totally benign respiratory virus can trigger that massive prostaglandin release just as easily as an invasive bacteria. The height of the fever just tells you the immune system is fighting hard. It doesn't tell you what it's fighting.
Okay, so if we can't trust the thermometer, what are we supposed to rely on? Because the physical exam can be so ambiguous in infants. We need something highly sensitive to alert us.
And this is where the webinar elevated something that standard protocols often completely ignore because, well, it's entirely subjective.
Which is?
The raw intuition and deep concern of the parents or of an experienced clinician. Professor Gressligan made a massive point to treat parental concern as a vital sign.
I really love that concept, but how do you quantify a parent's intuition? A lot of parents are just naturally anxious when your baby is hot.
It comes down to understanding the nature of the data they are providing. Think about it. As a clinician, you are getting a snapshot of that child at 2 a.m.
Right.
But the parent has high-resolution longitudinal data. They know the child's exact baseline.
That's a great point.
So if a mother says she is just sleeping differently or her color is off, that is a highly sensitive observation of systemic decline that might not ever register on a standard pediatric early warning score.
That makes total sense. So for you listening right now on your next shift, don't just ask how high the fever was. Ask the parents why they are concerned tonight. Ask them what specifically looks different from the last time the child had a cold.
Exactly. And Professor Gressligan pointed out during the Q&A that understanding the root of their concern changes your entire pathway.
Right.
Differentiating between a parent observing a radical behavioral change versus a parent who's just anxious about daycare rules tomorrow, that is critical.
But of course, if we are relying on a parent's gut instinct, we eventually have to scientifically validate that instinct, right? I mean, we can't just chart a bad vibe and prescribe powerful drugs based on it. We do need objective data.
Right, we absolutely need the data. Which brings us to the actual testing.
Yes, let's talk about testing. Let's say you've done the exam, the child is very young, the clinical picture is ambiguous, and the parent is worried. We need blood work.
We do, but the webinar made it incredibly clear that the old standard like total leukocyte counts or white blood cell counts are essentially obsolete for making these critical distinctions.
Obsolete, really?
Yeah, they're far too blunt an instrument. I mean, the total white blood cell count reacts to stress, crying, viral infections, and bacterial infections almost indiscriminately.
It's too noisy.
Exactly. Instead, Professor Gressligan highlighted the power of specific biomarkers, primarily comparing C-reactive protein, or CRP, with procalcitonin, or PCT.
And she showed a graph comparing the kinetics of those two markers, right?
Yeah.
That completely shifted how I view emergency blood panels. Why does procalcitonin react so much faster than CRP?
It comes down to where and how they are produced in the body. So CRP is an acute phase protein synthesized almost exclusively in the liver.
Okay.
It takes time for the inflammatory signals to reach the liver, for the liver to produce the protein, and for it to accumulate in the blood. CRP typically takes, 12 to 24 hours to peak.
Which is a long time when you're waiting in the ER.
A very long time. But procalcitonin, on the other hand, is a peptide precursor of the hormone calcitonin. Now, in a healthy state, it's only produced by the thyroid gland. But during a severe bacterial infection, multiple tissues and organs throughout the entire body suddenly start producing and releasing PCT.
Wow. So it's like a systemic alarm going off everywhere at once rather than waiting for the liver's localized siren.
Precisely. PCT increases in the bloodstream within just 2 to 4 hours of a bacterial infection taking hold.
That is fast.
Very fast. And crucially, viral infections actually suppress PCT production.
Oh, wait, they suppress it.
Yeah. So if you have an early onset fever, say a child who spiked a temp just 3 hours ago, CRP might still be totally normal because it hasn't had time to rise. But a PCT test with a cutoff of 0.5 is significantly more performant at detecting an invasive bacterial infection early on.
That is incredibly useful. And the speakers didn't just share the theoretical biology, right? They shared massive clinical proof, like the French diaphragm study.
Oh yeah, that study was huge.
They looked at over 5,000 children across 25 different emergency departments. And they implemented a strict PCT-based algorithm using rapid point-of-care testing.
And having point-of-care testing is vital there because you get the PCT result in roughly 20 minutes while the child is still in the department, rather than sending a tube to a central lab and waiting hours.
Right.
And the study observed a significant decrease in antibiotic prescriptions by day 15 because they could confidently risk stratify the children right on the spot.
But the most staggering outcome of the diaphragm study wasn't just saving antibiotics. It was safely reducing the number of lumbar punctures performed, specifically in the highest risk group, babies under 1 month old.
Yeah, that was a game changer.
I have to push back here, though, because for a lot of people listening, this feels terrifying. For decades, the dogma in neonatal medicine has been that any neonate with a fever automatically gets a full septic workup, including a lumbar puncture. Full stop. So how do you convince a seasoned doctor to skip an LP on a 3-week-old infant?
Well, by relying on the data. The study proved non-inferiority for morbidity and mortality.
Meaning it was just as safe.
Exactly. Relying on the PCT algorithm instead of the automatic lumbar puncture did not result in sick babies slipping through the cracks and developing meningitis.
That's amazing.
It really is. The biological marker was sensitive enough to catch the bacterial infections, which spared thousands of healthy infants a painful, invasive, and, potentially traumatizing procedure. It's just a monumental shift from aggressive, generalized protocols to individualized, biomarker-driven care.
Which is the dream, really.
Yeah.
And it also highlights something Profila Nail brought up during the Q&A, which is the sheer diagnostic value of observation.
Yes. Time itself is an incredible diagnostic tool.
Yeah.
Instead of rushing to an invasive procedure like a urethral catheterization or a lumbar puncture the minute an ambiguous patient arrives, modern medicine is increasingly leaning on acute assessment units.
Where you can just watch them.
Right. Simply observing the child for a few hours in a specifically designed unit allows you to watch the trajectory of the illness. A child with a severe bacterial infection will declare themselves clinically over a few hours, whereas a child with a virus often, perks up after a dose of antipyretics and some fluids.
Which brings us to the hardest part of the job, that 2 a.m. conversation with the parents. You've done the clinical exam, checked the biomarkers, maybe even observed them for a few hours. You are scientifically confident it's a routine viral illness.
Right.
But you still have to translate that high-level science to a parent who is staring at a 40-degree thermometer and panicking. So what is our actual goal when managing a fever?
Well, Professor Gross-Leguen presented a really fascinating comparison of international guidelines from the WHO, the American, UK, Canadian, and French pediatric societies. And despite minor differences, they all agree on one absolute consensus.
Which is?
The goal of pharmacological treatment is solely to reduce discomfort and treat distress.
So treating the distress, not the number on the thermometer.
Exactly. There is zero medical need to systematically force a child's temperature back down to normal. The fever is a symptom, not the disease itself.
But try explaining that to a terrified parent.
Oh, I know. It's tough.
Parents come into the ER armed with generations of well-meaning but totally incorrect folklore. Professor Gross-Leguen actually did this rapid-fire myth-busting session during the webinar that explains the actual physiology behind these fears. Let's walk through them.
Okay, let's do it.
Myth number 1. High or rapidly rising fevers cause simple febrile seizures.
Yeah, so the biology tells a different story. Simple febrile seizures are caused by the inflammatory response, that massive wave of cytokines hitting an immature developing brain. It's not the absolute height or speed of the temperature spike itself.
Right.
And because of this mechanism, giving antipyretics like paracetamol does absolutely nothing to prevent febrile seizures.
It's so counterintuitive, but so important. Okay, myth number 2. A fever over 40 degrees is inherently dangerous and can cause brain damage.
Again, we go back to the hypothalamus acting as the thermostat. The body is deliberately turning up the heat to create an inhospitable environment for the virus. The temperature will naturally cap out before it reaches a level that denatures human proteins.
So it regulates itself.
Right. The severity of the illness depends entirely on the underlying bug, not the heat of the response.
Okay, myth number 3. You should use cool baths or tepid sponging to aggressively bring the fever down. I see parents doing this all the time.
Oh, yes. And this is a classic example of working against the body's physiology. Think about the thermostat mechanism we talked about.
Yeah.
The hypothalamus has set the body's target temperature to 39 or 40 degrees. If you put a child in a cold bath, you cool their skin, sure. But their brain still demands the higher temperature.
So they start shivering.
Exactly. The body initiates severe shivering to generate heat and fight the cold water. This massively increases the child's metabolic demand. It burns energy they desperately need to fight the infection, and it just makes them absolutely miserable.
I mean, when you have the flu and the chills, the last thing you want is a cold sponge bath. So why do we do it to screaming toddlers?
Exactly.
It just feels like we are treating the parent's psychological need to do something.
Yep.
Okay, myth number 4. Suppositories are the best way to treat febrile children who won't take medicine.
Well, Professor Grasse-Lagun noted this is quite common in France, but her advice was to abandon them.
Why?
Because the absorption of medication in the rectal mucosa is highly erratic and unpredictable. Plus, it's invasive and traumatic for a sick child. The international consensus is to stick to oral paracetamol as the first line, dosed at 15 milligrams per kilo every 6 hours.
Got it. And finally, myth number 5, which is perhaps the biggest driver of midnight emergency room visits. Parents will say, I gave them the paracetamol and the fever didn't break. It must be a dangerous bacterial infection.
Yeah, but the response to an antipyretic does not predict the severity or the etiology of the illness.
It doesn't.
No. Paracetamol works by temporarily blocking the synthesis of those prostaglandins we talked about earlier. But if the viral load is high and the body is aggressively fighting, it might simply override the medication.
So it's just a strong virus.
Exactly. A stubborn fever doesn't mean it's bacterial. It just means it's a strong inflammatory response.
When you lay out the biology like that, it's pretty clear that historical fever management has been largely about managing parental anxiety. We focus on the number because it gives us a metric we can easily measure and, temporarily control.
Right.
But during the Q&A, someone asked a great question. How do you reassure parents when there is always that 1 to 3% chance of a severe invasive infection? And Professor Grasse-Lagun's answer was profound. She said that to reassure the parents, you must first completely reassure yourself.
I completely agree with that. You cannot project calm if you are internally second-guessing your own exam.
You just can't.
You have to do a rigorous, thorough clinical evaluation. Document the heart rate, the respiratory rate, check the peripheral circulation. Once you have firmly established that there are no red flags, you have the clinical certainty required to look the parent in the eye, validate their concern, and give them clear, actionable instructions on what specific symptoms should prompt a return visit.
Yes. And looking ahead, our ability to achieve that clinical certainty is going to get even faster. The webinar ended by looking at some really cool innovations coming down the pipeline.
Yeah, the future tech part was amazing.
Like, for instance, dealing with unexplained fevers often involves ruling out urinary tract infections. Professor Grasse-Lagun discussed the implementation of faster clean-catch urine collection methods that eliminate the need for unreliable adhesive bags or traumatic urethral catheters.
Which is a huge relief.
But the technological leaps they discussed were incredible, like multiplex PCR analysis.
Oh, this is fascinating. Imagine swabbing a child's nose and within 15 minutes using a point-of-care PCR machine right there in the emergency department to screen for more than 15 different respiratory pathogens simultaneously.
In 15 minutes?
Yeah, it just completely takes the guesswork out of viral diagnoses.
Wow. And even more fascinating is the development of host transcriptional signatures. I mean, how does analyzing messenger RNA actually distinguish a virus from a bacteria?
It's a totally different approach. So traditional tests look for the burglar. They try to find the specific pathogen in the blood. Host mRNA signatures don't look for the burglar. They look at the home's alarm system.
I love that analogy.
Thanks. When a virus attacks, a child's cells read a completely different set of genetic instructions than when a bacteria attacks. By analyzing the messenger RNA expression in the child's blood, we can read their genetic defense manual in real time.
That's wild.
It is. We can see exactly what kind of threat the body is mobilizing against, which definitively distinguishes viral from bacterial responses.
That is just incredible. So to synthesize everything these experts shared at the April webinar, we are witnessing a true maturation in pediatric medicine. We are learning to trust parental intuition and longitudinal observation.
Yes, absolutely.
We are shifting to targeted biomarkers like procalcitonin instead of clinging to the dogma of routine lumbar punctures. And we are remembering that a fever is a biological symptom to be managed for comfort, not a disease to be eradicated.
Right. It is about treating the distress of the child rather than the anxiety of the adult in the room.
Well said. Which brings me to a final thought for you to consider on your next shift. We discussed how parental intuition, that mother's gut feeling that something is fundamentally wrong, is one of our most sensitive diagnostic tools.
It really is.
But as we look at these future horizons, what happens in 5 or 10 years when every infant is wearing a medical-grade smartwatch that tracks their baseline vitals, sleep cycles, and temperature continuously? Right. Will algorithms and continuous data tracking eventually replace the gut instinct we rely on so heavily today? Or will the human element always perceive a shift in a child that the sensors simply cannot measure?
That's a fascinating frontier to consider. Because as technology gives us more data, figuring out how to, weigh it against human observation will be our next great challenge.
Definitely something to chew on. Well, if you want to see the actual biomarker kinetic graphs, the diafever study algorithms, and the full Q&A session we discussed today, the complete webinar recording of Managing Fever in the Child is available right now on the EAPS Education on Unlock portal. We highly recommend you check that out to see the data firsthand.
And for those of you who want to continue this practice-changing conversation in person, we warmly invite you to join us at the next EAPS Congress. It will be taking place in Athens from the 24th to the 27th of September, 2026.
We hope to see you there, and we wish you well on your next shift. Thank you for listening to this episode of Pathways in Pediatrics.